Good afternoon, everyone. It's a pleasure to be hosting today. My name is Dr. Ahmed Wobi. I'm a radiologist and also product manager here at 33N. As part of the session, I'm going to be hosting the final part of the 3 parts from Beyond Pilot Series, looking at how AVT and live deployments across the NHS, specifically discussing how organizations are able to move from the pilot stage and achieving sustainable scale and adopting different productivity measures that can drive and enhance patient care. So in today's session, we're going to have a look at what it takes to move from an individual isolated successful pilot to an organization-wide or system-wide adoption of an AVT. And we're going to be looking at critical enablers of sustainable scaling, from things like safety and embedding governance into managing the wider change, as well as ensuring that we have information parity and building the right kind of digital capabilities across all teams. And the discussion is also going to consider what good looks like in a mature AVT deployment, including the lessons learned from live CLEARnotes implementations. A reminder for everyone today that the webinar is going to be recorded, so we can share it afterwards on our website across different networks. So just to start with, a very quick introduction as who will be speaking and the different topics in the agenda. So starting, we've got Dr. Shruti Dalakia. She's the NHS anaesthetist and Chief Product Officer at 33N. Is going to be talking about the critical enablers of AVT. Next, we're going to hear from Dr. Dominic Sebastian, who is Divisional Medical Director for Surgery and Anesthetics at East Lancs Hospital Trust. Then we're going to hear from Rachel Brown, who's the Deputy Chief Operating Officer at the Royal Wolverhampton NHS Trust. And last but not least, we're going to hear from Professor James Teo, who's Chief Medical Officer at CogStack. And for the agenda itself, specifically, we're going to be looking at the 4 main areas around critical enabling of AVT from isolation to wider deployments after pilot. Going to be looking at the work that's been done specifically at East Lancs from Dr. Dominic Sebastian, and Rachel Brown's going to be taking us through the specifics that happened at the Royal Wolverhampton Trust, including the processes that they've been successfully adopting, enabling smooth adoption. And last, we're going to hear from Professor James, who's going to be talking about how CLEARnotes is able to work in the platform of CogStack, and that allows different sites to do more with their data and within an EPR setting. We have a discussion at the end, so we'll be picking up different points that have been made during the presentations, and this will be an opportunity to share any insights that have come across during the talks and ask questions of our speakers. So if you do have any questions or comments, please pop them either in the chat or raise a virtual hand at the end during the Q&A session. We have a hard stop at 4 o'clock, so if we just remind the speakers, if you could please stick to the timings, that'd be greatly appreciated. And that's all for me for the moment. So I'm going to hand over to Shruti, who's going to kick off with the first session. Thanks.
Thank you. Thank you, Ahmed. So I'm going to be talking about making the AVT pilot stick and then trying to scale it up. Next slide, please. I think before we start, it's important to understand as clinicians, writing your notes about your patient encounter is just as important as seeing the patient, because it is your written record of what has happened with that patient. And it's fundamental to how you learn to see a patient and then what you do with their care. So technology has seemingly changed this overnight. And so what's really key is that people aren't going to change nearly as quickly as the technology has allowed us to. So going from pilot to large scale transformation is really about the transformation journey that you take everybody on, because you are changing something fundamental in the way that they work and the way they think about their interactions with patients. So early pilots for us have showed really high engagement and really nice outcomes. And AVT is proving itself to provide clinical value. But moving from these pockets of excellence to then everyday use is, as I described, is where the challenge lies. And what you have is in pilots is the ability to adapt, adopt, think flexibly, and move together in a small team to try and make big changes. But that's not the case when you take something so transformative and scale it across large groups of people. Next slide, please. So, like I said, so close support from the 33N team, flexibility on the participating teams side and on the 33N team side, and loads of enthusiasm makes pilots go a long way, and it's amazing, and we've had some really wonderful results. But what we know, full-scale success isn't about the technology, it's about the transformation, and transformation is key on several factors, and this includes leadership and leadership alignment, the operational sponsorship from the trust itself or the institution, and governance and change discipline. Next slide, please. So what we've learned around leadership and sponsorship. So when you have a small team that's led well and can be very dynamic, goodwill and flexibility can get you a long way. But what we've learned in the scaling is that you need to define upfront senior responsible officers, operational and clinical leads together. And what we know is that the introduction of technologies such as AVT not only impacts the clinicians, but it impacts the ops team and the administrative team. And they all need to be present and talking about how the tool is going to enter their workflows and change their workflows for the better. So we take a real emphasis on clinical and operational shared sponsorship, and really try and understand the leadership dynamics that exist in organizations and how we can work well with those to ensure the smooth scaling of AVT into the clinical teams. So next slide, please. So what we've learned with regard to clinical engagement, small teams that are led well clinically builds a lot of team trust and builds belief, but that doesn't necessarily automatically translate into scale. Because as you know, across trusts, for example, you have different teams that behave in different ways. They have different dynamics and different subcultures. So what you need to do is introduce levels of standardization that the transformation work can take these teams on a journey that helps them understand how their working lives are going to change, how their interactions with their patients might change or might not change, and how they can work together as a clinical team and institute a type of technology that's pretty amazing, but also will introduce big fundamental shifts in how clinicians work and think about their work associated with patients. So what do we do? So we formally have specialty kickoffs before we go live. We spend a lot of time thinking about where does the tool fit into the current workflow and how might the workflow with the clinicians and the patients change. And if that seems that it's going to be substantially different, we then have to go on that transformation journey as well, helping the clinicians, the nursing staff, the administrative staff understand how their fundamental interactions are going to change and how they can go on that change process and introduce the technology at the same time. So we've introduced very clear scope around the teams that we engage with and how we'll engage with them, and then set out timelines. And if we can see from the outset that clinical transformation is required, be upfront about it and say that those clinical transformations are going to add to timelines or might complicate timelines. But we agree responsibilities, roles, and we take it forward with everyone being completely cited on what we believe and what the clinicians believe needs to happen in order for the right change to happen, in order for the technology to be embedded well into their team's working, and their team's culture. Next slide, please. So what have we learned about operational management? The ops teams, the administrative teams that hold it all together, that work behind the scenes to make sure that the right things are happening at the right time and the right way, so that if at any point we need to stop or go back, audit, anything like that, we've got the correct processes and the correct paperwork. We've got everything that we need to go back and check or manage events as they may arise. So, like I said before, we make sure that the ops team, the administrative teams, and the clinical teams are all cited together, and we work with this triad of individuals, or identify the appropriate individuals to create these triads by which to work and go forward with. Ops sponsorship is really crucial because as it says here, determines the pace at which you can move through the hospital. So, for example, some hospitals that we've worked with are separated into divisions. So you can go from one division to another division very easily if the ops teams in both divisions understand how each other are working. They say, this is how you're going to do it. This is how we've done it. And there is that ability to translate plans from one division to another division, even though the clinical content of those divisions might be vastly different. It's the ops teams that will help you get a foot in and get going in those divisions quickly. So, our key lessons are: involve the ops teams. Don't assume one workflow fits all. That's absolutely not the case. And it's not the case also, it can also not be the case for the different types of ops teams. But we've found that actually there's a lot more similarities than sometimes you might find between different clinical teams. And integration with the EPR is an interesting one, and often is set out as a prerequisite. But like I've said before, the answer to success isn't necessarily in the technology. It's about introducing the technology well amongst the teams. Next slide, please. Implementation and governance. So a pilot, like we've said before, can be set out in it feels easy, it feels flexible. It doesn't feel like there's too much weighing on it. But as soon as you start to scale that up, it means that it becomes more like a program. Larger pilots or scaled pilots are not really pilots, they're really verging on programs. So you should give it the respect it deserves and treat it like a program. Next slide, please. And that's what this slide's all about. So if you have your governance in place, you've got your processes and all the compliance paperwork, everything like that in order, you've got teams that understand what's going to happen in terms of the steps that need to occur in order to get clinicians live and up and running on the technology. It's really helpful. So think of them as programs of work and not pilots when you scale, even though they might be under the banner of an extended pilot. So the key principles here are clear criteria for moving from pilot to program, and that's in the sponsorship, the funding, the evidence bases that you're using. Try and maintain agility. It's always nice, but also adopt the program level discipline. As I said, give it the respect it deserves, and do avoid the extended pilot trap, because actually that's not what you're doing. It is a program of work, and actually it's a pretty huge piece of work in that sense. When you think back to taking notes is such a fundamental part of clinicians' education, learning, day-to-day practice in their interactions with patients, and for delivering safe patient care and making appropriate records in the notes for what has happened to that patient whilst they've been in your care. Next slide, please. So these are some of the outcomes and impacts that we've encountered, and really it's what we've done is really think about addressing the points around leadership, workflows, and integration head on, and being very transparent in our program boards, regular program boards that we hold. Next slide, please. So this is I've said it several times now, but this is our framework for scaling AVT. So again, it's like leadership and alignment, structured management, take governance first approach. It's a program, not an extended pilot. Integration options, integrated operations. So align your digital teams, your patient experience teams, your ops teams, your admins teams. You need everyone to be working together. and do it on an evidence base as well. So transition based on data, not on enthusiasm. Enthusiasm will get you a long way, but what you need is that consistent achievement of the clinicians and their successes to help you move on to the next team. Next slide, please. And I think it's important to just close off to say that the CLEAR program itself is really all about transformation and complex transformation in the NHS and in healthcare settings. So tools will come and go, but helping people on that change journey will always be there. Thank you. I'm going to hand over now to Dominic Sebastian, Medical Director at East Lancs.
Thanks, Nimisha. Just for correction, I'm Divisional Medical Director at Division at East Lancs. Okay, so hi everybody. So I'm going to be talking about how we scale or intending to scale the ABT technology within the division. So I'll start off with our journey with a pilot. So the challenge that we had was we introduced an EPR within East Lancs, and that increased the administrative burden within all clinical areas that comes along with any introduction of an EPR. So the challenge was we aimed to try and reduce the admin burden in the pre-op assessments clinical area, so that we lost a lot of time addressing the paperwork or the inputting into the EPR that consumed a lot of time in the pre-op assessment. And the assessments also felt quite impersonal and cold because there was always a computer screen between the patient and the clinician at that point in time. So Tony Bell, my team manager in the pre-op assessment area, together with the pre-op assessment nurses, identified a solution, which was CLEARnotes as an ABT. It helps transcribe that conversation between the clinician and the patient and delivers a structured clinical note within a few seconds. And that was the breakthrough that we had. The vision was how do we harness the ABT to cut the admin burner? How do we free up the nurses to focus more on patient care and interaction and build a more efficient and compassionate and pre-op service? And that was also to help build the morale of the pre-op nurses at that point in time. Next slide, please. We applied to be part of the NHS England pilot. We needed something innovative to boost our productivity that dropped following the introduction of the EPR. Our service became the first site to pilot CLEARnotes through the NHS-funded program. Aim was to reduce admin appointment time at 10 minutes, increase safety and consistency on the documentation, initial increase in productivity by at least 10%, and reduce current costs with regards to dictation. That was a long-term plan, reduce staff fatigue and improve morale, and improve the patient experience. We move on to the next slide, please. So we compared data for the pre-CLEARnotes, the 19 weeks pre-CLEARnotes and 25 weeks post-CLEARnotes. The number of consultations that we had pre-CLEARnotes was 5,292 in the 19 weeks, and we had 7,739 post-CLEARnotes consultations in the 25 weeks. The median time that, the median amount of appointments that we achieved was 55 in the pre-CLEARnotes week and 63 in the post-CLEARnotes week. So we showed an increase in productivity of 14% in that period of time. Next slide, please. So we had a sustained productivity of around 14% boost in that period of time, to the point that in this current week, we're talking about creating a template that will deliver an increase in pre-op clinic templates of 20%. Just a minute, please. Bring it down to 2%. Increase the productivity, increase the clinic templates in the pre-op clinic by 20%. So that's what we intend to do going forward. So this increase in pre-op assessment happening in the pre-op clinic has helped to a certain extent maintain our 85% or greater than 85% CAP theatre utilization. And as all of us understand, CAP theatre utilization is essential to achieve for all of us within the NHS. Achieving a greater than 85%, consistently achieving a greater than 85% has increased our productivity right throughout everywhere. And it has contributed by addressing multiple factors in that journey of ensuring that theatre efficiency is maintained. I'll go to the next slide, please. Scaling. So now that we demonstrated that there is a productivity gain in the pre-op clinic, how do we build on it? And I already talked about changing our template within the pre-op clinic to 20%. So within the surgical division, our intention is to scale it in all other directorates within the surgical division. In the surgical division that we have 12 directorates. We intend to scale it up to by 6 directorates. The drivers being improving documentation, making the documentation more consistent and standardized, reducing the clinician's time in the outpatient clinic, reducing the typist time further downstream, and hence reducing the requirement for waiting list initiatives to deliver planned activity. Better data visibility across the perioperative pathway, especially with regards to the conversations that happen in the outpatient clinic. The conversation is very much transcribed into the outpatient notes. So the richness of that conversation is transcribed into the EPR, and it actually makes it more visible as to what conversations happen in the outpatient clinic. It aligns with the wider digital strategy within the organization and within the NHS. Thank you. Next slide, please. The lessons learned to scale up, and like Shruti already mentioned, when we set up a pilot, we only focus on the small group of individuals being extremely flexible and aligned with the vision that we have. But when you try to scale it up, you involve lots of other people in it. So different professionals in all of it, the clinicians, the nursing staff, the admin staff, the operational staff, all of them need to align with the vision. So in terms of leadership, within the division, we require an SRO to deliver the scale up, and it has to be shared with the operational and the administrative side of the division. Clinical advocacy isn't enough. It might be okay for a few clinicians to say, yes, they want to try it out, but it requires the whole directorate to actually understand what the future vision is to actually deliver the scale up. Clinician engagement. We have a lot of enthusiasm from the CLEARnotes team. We have a lot of enthusiasm within the clinical team, but you will have a few early adopters and you will have a few people that are very resistant to take it on. So utilizing the early adopters is essential to actually demonstrate to the others that there is a benefit here. So we've kicked off in 6 specialties at this point in time. It is a continuous process of learning of how, when you scale up. It requires a degree of flexibility, but it requires a degree of standardization, but it is a continuous process of learning. And so it is an iterative workflow design that must happen. And so we meet up every week to try and understand quite a lot of it. Operational engagement, Shriti's already mentioned about the operational engagement. If we bypass the operational side of it, potentially the scale up never happens. Although it is a surgical division, although it's surgical specialties, all specialties function very differently, even in something similar as simple as an outpatient clinic. So understanding the complexity and the intricacies of the surgical workflows in the different directorates is extremely useful. EPR integration is also essential to actually scale up comfortably. Not having EPR integration introduces an element of risk, but that's a different part of the conversation we'll have. Next slide, please. Closing thought. The pilots are pretty simple to set up and show increase in productivity. Scaling up is a lot more complex process. It requires a lot more thought. It requires a lot more discipline. It requires various clinical, operational, and admin teams to claim or understand the ownership that they have. It requires very good governance and a constant eye on the governance side of it, and to be safe and to be also sustainable long term. I'll stop there. Thank you. Rachel, I think you're next on this. Thank you.
Thanks, Dominic. So hi everybody. My name is Rachel. I'm the interim deputy Q at the Royal Wolverhampton Trust. Just a little bit about the organisation in terms of us. So we are an integrated trust, so that means we've got an acute bed base as well as a community setting as well. But I think the one thing that makes us slightly different is that we've also got 9 GP practices that are employed by the organisation. So they make up one of the 6 PCNs across the whole of Wolverhampton. So in terms of scalability and efficiencies at scale, it means that we kind of run across the whole of the system, whether that's acute, community and primary care. So first slide, please. So similar to what Dominic said earlier, I feel like we've got, we were part of the initial pilot phase, and some of the drivers taking part in the initial pilot was around our elective recovery and efficiency. So we recognised that we've got some really long waiting times, and we had a really over-reliance on additional clinics in terms of WLI. And that some of that was being driven as well around the improvements in terms of documentation speed. We've got a massive workforce strain in terms of paperwork and the paperwork burden, and that had an impact in terms of not only staff wellbeing but also to retention of staff as well. We recognised that we wanted to do some digital strategic alignment, and we wanted to be able to meet some of our national and digital goals around what that looked like. We had quite a huge ambition in terms of our innovative roadmap as well for digital within the organisation. We recognised that one of our other drivers was that impact on patient outcome and experience. We were carrying at the time quite a significant risk in terms of kind of length of appointments getting back. So our KPIs around turnaround of letters was quite lengthy, up to almost 12 weeks for some individuals. And what that meant from a patient perspective is that referrals didn't get done in terms of a secondary resource, but equal just in terms of time and access to documentation as well and information for them. So our goal when we originally started the initial pilot was around having some technology that improved not only patient flow but also staff experience as well. Next slide, please. So some of our pilot, similar to what Dominic said, we were part of an NHSE funded pilot which ran for 6 months, and that ran early this year between March and April. We picked, similar to Dominic, which was a pre-op assessment clinic, and that was one of our consultant-led clinics that we had within the Wolverhampton. And around that, what we were really hoping to achieve was around evaluating safety and efficiency and experience, but also that ability to scale up. And we wanted to make sure that it was kind of seamless in terms of our work streams. We didn't really want it to disrupt any clinical practice. We didn't want it to be an add-on to current workflow. So we didn't want it to actually create more work. We wanted it to actually help in terms of that workflow. And so really what we wanted to do was be able to kind of, by being part of the pilot, was to provide us with some evidence in terms of where could we go with this from a wider but also a sustainable adoption across the whole and wider organisation. Next slide, please. So in terms of key aims for the initial pilot, it was around making sure that we had clear and very robust information governance and safety standards around and measures around implementing a CLEARnotes process and ABT model. it was around upskilling our staff, because we recognised that not all of our staff were particularly technically agile, but equally around just in terms of that building their confidence in terms of AI tools as well. We really wanted to be able to co-design and redefine some of the processes that we've got, and we hope that the technology would be able to help us with that in terms of the clinical, but also the IT input as well. And we wanted to be able to evaluate not just from a user perspective, but also from a patient acceptance as well. So what did it really feel for those individuals going through that clinic setting as well? And then also in terms of understanding and measuring the quality benefits and risks overall attached to AVT. Next slide, please. So overall impact of the pilot, which is obviously now concluded, we were able to see a 63% reduction in administrative time within those clinics, and that released about 46 minutes per clinic for those clinicians. And that was based on, the difference between, seeing 4 patients in a clinic to 5. In terms of the admin burden, particularly in their clinics, it reduced and almost streamlined some of our processes that were associated with those clinics, and it led to a 75% reduction in clinic processing time, and that meant that it went from a 6-day turnaround to a 1.5-day turnaround for those individuals. The processing time also improved, so it averaged out about 10 seconds per consult. So our consultations lasted on average around 20 minutes and 47 seconds, and that excluded any other tasks that might have been needed as well. Prior to the pilot, we had quite an over-reliance on outsourcing letters just to keep up with the demand in terms of the administrative burden around that. So that went to a 66.7 reduction in outsourcing of letters, but equally, more importantly, from an organisation point of view, it led to a 60% cost reduction as well. So in terms of clinical acceptance and usage, that significantly improved as cost part of the pilot. So I think initially when we started the pilot, we probably got about 6 clinicians that were interested in taking part, and that rose to around 7 by the end of the pilot. So we really improved in terms of having that facilitated feedback to the developers, listening to kind of where we wanted to get to in terms of that peer engagement as well. And we really improved that going forward as part of the pilot scheme that we went through. Participation, just from an organisational point of view, helped us position in terms of the trust, in terms of leading on AVT sites. So again, that in terms of reputational across the ICS, and also helped in terms of our ambition to kind of scale up the technology across other service. So it really gave us a platform and a stepping stone to be able to do that, and to do that efficiently within the organisation as well. And we really found that the consultation quality improved dramatically as well by using AVT. So just being able to give constructive feedback around what that looked like, and the patient conversation in terms of not being focused on a screen the whole time, but being able to have a full-on conversation with that individual patient was really beneficial. Next slide, please. So as well as that overall impact in terms of from an organisational perspective, just in terms of people and culture in that directorate, it really had some great positive feedback as well. So from a clinician feedback, our clinicians felt that the patient interaction was much better. They weren't just looking at a screen constantly during their consultation period, but it also meant that they were far more engaged with that individual and made it a much more beneficial consultation process. It meant as well there were less admin as part of that as well. Our note quality completely improved, and the editing became minimal, so we weren't going back and then rereading notes and then kind of making significant changes. It felt very much from a clinician's point of view that it was very transformational. It wasn't just around putting some tech in to kind of solve a problem, and it was just we're doing tech for tech's sake sort of thing. From an overall workforce enablement, it really felt like they were putting people first and the process second, instead of kind of being driven by, the computer says no, you're not allowed to do that. So people really liked that. It meant that we were able to position AVT as a service transformation and not just a digital rollout. I think that was really important in terms of that transaction, not being transactional, in terms of how can we then transform some of the other things that we're doing around it as well. It also gives an opportunity to create some local champions, and actually that will help in terms of our trust momentum, in terms of scaling up and rolling out of the programme as well going forward. Next slide, please. So in terms of scaling up for the growth and what that kind of means, so our goal really is to scale up across services where we've got a real high documentation demand and also in terms of workforce strain. So we really know that we've picked some areas that we've got some particular challenges going forward. So we're really clear that we're going to do a phased rollout and we need to make sure that that's managed and obviously evidence-led. Across the organisation, we've got 3 clinical divisions. So unlike Dominic, where he's kind of focused in on the surgical directorate, our directorate's really diverse, as I mentioned earlier. Our organisation is both acute and community as well as primary care. So it means for us that we kind of really want to scale up in terms of different areas to kind of show different impacts. So some of our clinics and some of the areas that we'll be looking at are working within predominantly outpatient settings, which is like rheumatology and dermatology, but also some of our community centre, community paediatrics, as well as looking at some of our AHP clinics as well in terms of podiatry and orthotics as well. We're going to really learn from some of our early adopters, so we're going to do it in terms of waves of services that are going to go on board. So by that, what we'll hope is that we'll gain a bit of momentum. So our early adopters will then kind of help inform and kind of engage with some of our other services that are going on after them as well. We want to progressively build on that buy-in. So how do we engage that and not enforce it? So again, working with our colleagues that are going in the first wave to then kind of help us engage with the other services that are going on board as well. So our outcome at the end of the scaling project is to have 9 directorates live by month 6, and then to realise some of those benefits by month 9 of the next programme. Next slide, please. So this is what our rollout plan looks like if we were doing a pure project plan. So we're looking at around circa about 200 staff that will be scaled up in using CLEARnotes going forward. So you'll see we're very much in the early stage of our project setup time. So again, it's around making sure that we've got all our IG signed off in terms of what that looks like and confirming, looking in terms of our process mapping processes and kind of looking at understanding where do we need to get to with each individual directorate. It's also important around in making sure that we've got training for those users to make sure that they're really clear. And I suppose the most important thing for us is having some dedicated data identified in terms of our baseline measures. So when we get to the end point, we can really have some useful evaluation and performance data that can show where we've come to in terms of where we are and where we've come to. Unlike other places, was just in the middle of an EPR rollout. So at the minute, we're not going to do any connectivity in terms of how it will connect with our new EPR, and that's purely because we've literally gone live in September. So we feel like we need a little bit more time to embed in that before then we do some integration with our full EPR system. Next slide, please. In terms of what good looks like for us in terms of ABC deployment, we really need it to be embedded in our daily workflows. We don't want it to be added on to work that we're currently doing, so it needs to be a seamless transition into the work that we're currently doing. It needs to be trusted and clinically, and so our clinicians, despite us working as a really integrated ops teams, need to be really engaged and also like own a system that they want things to be putting through. We're really keen to make sure that it's data driven, so making sure we've got those baseline data measures in place so we can really see some high productivity and safety insight and gains by doing this piece of work. We know that to kind of keep momentum in terms of the scale up of where we want to get to, we know that we've got to do some sustained clinical engagement and also some wellbeing gains. So what is it that we're going to get out from each individual clinician? The patient experience is really important to us, so we need to make sure that our patients will listen to and engage to, and that it really is a really meaningful consultation when we see those patients. And the most important thing for me is making sure that they have access to their information as quickly as everybody else does. The other big thing for us is recognising that it is a transformation tool and it's not transactional. So just in terms of scaling for lessons learned, it's about starting with real clinical need and not just taking fields of them, which we have quite a lot at Wolverhampton. It's about co-designing with our users from day one, so not making sure it's being done to them. The measuring and sharing the impact to build trust and also the belief that it kind of is the right thing to do and we're working on that. It's about scaling tactically and not instantly, so making sure we kind of got it right before we then upscale into our other directors as well. And it's about making sure that we keep the independence and trust with the core as well. Thank you. I think that was the last slide, I think. Thank you. So I'm just going to hand over now to Professor James Texel, who is the CMO at ProTech.
Hello, hi. Thank you very much for inviting me to this. Just for context, for those who are not familiar, Coxac is an NHS spin-out company out of London, and it's technology which was developed 10 years ago around language AI. And I'm also one of the medical directors at King's and Guy's and Thomas's, which developed this technology. So we've been doing this in the NHS for 10 years before becoming a company 3 years ago. The technology is what we would call interoperable, meaning that it can interact with other kinds of software systems like CLEARnotes and EHR systems. And our journey is a little bit different from where CLEARnotes are. CLEARnotes provides a complementary function in the sense that ambient voice technology helps with recording information. And that's obviously a big administrative burden, but there is also a second step of reading the information. And we support that bit. That's what we've been working on for the last decade. So let's move on. So what we do is we make text searchable. And how to make it searchable is that we are able to search across the entire record, across many patients, across the whole health record system, the same way you use Google, and we are able to code this data. And what I mean by code this data is to attach diagnostic codes, drug codes, comorbidity codes to the record like tags, and these tags can then be used to analyze the data or to trigger patient safety alerts or to do a variety of hospital or GP activity. And so if, let's say, you wanted to audit a cohort of patients with diabetes, you wouldn't have to find them manually on a spreadsheet or look at them one by one in the EHR. You'd be able to search. And so we provide this functionality, and we hope to work with CLEARnotes on this by building it together into the ambient voice. So next slide, please. So what we've been doing, one of the use cases we've been working on is around what we call clinical coding, which may be an activity some of you are familiar with or not. So clinical coding is a task in the back office of most hospitals and GP practices where people read what you have written, what the doctors and nurses have written in discharge summaries or outpatient letters, and then record what happened. So there are dozens and dozens of these individuals hired in most hospitals. And this reading task, after reading it, they record it in what we call codes, clinical codes like ICD-10, SNOMED, OPCS4, and this is how the hospitals and GP practices get paid. And also how we audit performance, whether or not we're delivering adequate care, how waiting lists are managed. So we know how many hip operations happen, who has had a hip operation already and who hasn't. And all this is what we call backroom stuff. But obviously, if we did deploy ambient voice technology everywhere, then we'll produce a lot of letters and a lot of text, but we still have the task of reading through all of them, which would expand exponentially as we would be able to write so much more with ambient voice. So what we need to do is a mechanism to read the text and match them with correct diagnostic codes and to do it in a scalable way. And next slide, please. We started to do that at King's, and basically that's the general thinking is that the person either fills in a form or dictates it in. Likewise, a radiologist might look at an image and do the same. A pathologist might do the same. Next slide, please. And then it gets stored as text in natural language. And then there's a second step below, which a clinical coder, registry, or audit manager reads and converts it into structured data. Now, what Coxac does is to deal with this bottom layer, whereas CLEARnotes handles the bit at the top. Next slide, please. So this bit here is where we supplemented with AI to help match the text, to read the text, and then highlight the different words and phrases and the grammar around it, whether the person has the condition or not, whether it was cancelled or not, whether the relative had it but not the patient. All that reading happens, and then it matches it with the health data, and then we use it to feed back into the EHR in standardized forms. Next slide, please. And so one task we did for Guy's and Thomas's during the pandemic, lots of the procedure codes of people in clinics were not being recorded. They were recorded in the free text, but they were not recorded in the forms. and hospitals are paid on the forms, not the free text. And so we use our technology to find all the text mentions, text of all the hip fractures, all the splints and casts, all the dressings, to find the mismatch between what was actually done and what was actually billed for or within the commissioners. And we found easily a few million pounds of undercoding in just one financial year, and it just took us 3 weeks to do. And so these are all things that hospitals are doing, but they're not being reimbursed for, largely because we don't know that we're doing it because we didn't record it in the correct form. And so our technology allows us to do that. Next slide, please. We did that as well in patient coding to capture all the comorbidities. As we know, there are lots of comorbidities which are often hidden away deep in the notes because it's just free text typed in or dictated in, and we match them with diagnostic codes like SOMAT-CT and ICD-10, which then, again, in many specialties, we find lots of activity that is not being recorded, and this matches with performance. Next slide, please. And likewise for waiting lists, we're finding patients who are being discharged or referred onwards, but no one actioned it because they didn't click the right button. And we match them. We find lots of missing, lost to follow-up scenarios. Next slide, please. This thing, unfortunately, is a movie which doesn't play, but essentially we show that it's fully integrated within our EHRs in Epic and in two of our trusts and in the Cerner Trust. Where we actually show how the codes are suggested back as people input the data in. Next slide, please. Oh. Next slide. Well, yeah. So essentially, how it works is that someone dictates, it goes into the CLEARnotes. Our system reads and maps out all the text to codes, and the codes feed back into the EHR as checkboxes if needed, or directly into the system. And next slide, please. And like every language, there is local nuance and accents or different styles of saying things, and we can tune it. So these are examples where a doctor or a nurse can tune the AI to match their style of writing or to match it to particular forms and to mark it as correct, wrong, and to measure performance so that unlike large AI companies elsewhere in the world, we are able to be deployed all locally in the hospital intranet. Next slide, please. And these things, we have built interfaces for people to do this. Oh gosh, this in the movie works here, where people mark the particular performance for the different ICD-10 codes. Okay, move next slide, please. So we have a variety of different tools, but obviously for the purpose of this, we are talking really about the coding element and how to link all this ambient voice work, our work with that, and to allow the richness of the text data that's generated by ambient voice to then be organized and tidied up in a format that is actually usable by the EHR. So then you can trigger alerts, you can trigger guidelines, you can produce risk scores and things like that. Next slide, please. Next, click again. Yes, so that from this we can generate registries. And so these are registries, for example, which is not playing, but essentially we can talk to all the data the same way you talk to ChatGPT or something, in which you ask it how many patients have type 2 diabetes and hip fractures and who are between the ages of 17 and 12 last Tuesday. And it will be able to find that because we search through the language of the record. So the reading is for me is as interesting as the writing. Next slide, please. And we are not just in the NHS. Some of our software we provide around the world. A lot of it is free, and so lots of people have downloaded the free bits and install it in different countries. We've got one in Monash, we've got a place in Thailand, we've got a place in Amsterdam, in Utrecht, in Rome, and so a variety of them. And we are working on these federations where a lot of the data is read locally and the AI is deployed locally and integrated within the local systems. Next slide, please. And so this is kind of really the summary, really. We use a lot of technologies. We link in with many different systems. We are very agnostic to many of the EHR systems as well as different data types. So we read not just the stuff you put in the EHR or into your notes, but also PDFs, Word documents, all sorts of stuff. So that's kind of the summary and how we're working. And in my context, obviously in King's, I work on this as a medical director, but I also advise the MHRA and the NHS 10-year plan on their AI strategy. Thank you very much. I think that's the last slide. Yep, thanks.
Thank you so much. That was really insightful. I know that I learned a lot. So thank you all to all of our speakers today, and for allowing us to learn about their journeys using artificial intelligence and pilot adoption and expansion. We're going to open up now to Q&A. So if there are any questions from the audience, if anyone wants to either put it in the chat or they can raise a digital hand, I'm more than happy to put that to the panel and get their thoughts on any of the learnings or insights that we've had today. Whilst we're waiting for that, I have a question myself. I guess for all members of the panel, what singular most important piece of advice would you give to an organization that is starting to adopt a new technology, whether it's an AI or an AVT, and how would they start that kind of journey, even if they are have just done a pilot, or if they're completely new to the to that kind of technology in their sector?
I'll give a go. I would say that there are more pilots than there are than there needs to be, and one almost needs to reduce the number of pilots and to work a lot more on the scale up, as others have emphasized, other speakers, is that the scale up into a program or into business as usual is substantially more complicated, and actually is the failing step for many organizations and many AI systems.
Okay, so it's about the quality, not necessarily the quantity. I see a hand up from, is that Rachel?
Yeah, it is, yeah. So just to come in on your question, I was just in terms of response, I'm going to say, building on what like Shuj said, it's very much about it's about the transformation that goes alongside it. So if we kind of treat it just about replacing one thing for another, so very transactional process, it don't quite work, because people don't get excited by that. So I think it is about that. How do we other things that come out of that process in terms of that transformation to do that work? It's definitely, I think, where it's key. And I think there's nothing wrong with giving stuff a go. I think we're trying a lot of organisations to make sure that everything's completely perfect before we start doing stuff. So it's very much about giving stuff a go and tweaking it as you go. So I'm very much about that PDSA cycle of learning in terms of, I've started it, this is working, that's not quite working, let's tweak it, and can I continue with it, instead of going, it's not really worked that well that time, so let's just stand back and not do it ever again. So very much about trial and error, I think, is really the way to go with stuff.
Yeah, definitely. That was a really nice one. A question in the chat from Jay. Will all of these AVTs and AI tools be soon Class 2A/B medical devices? I assume that's MHRA. This was my understanding from EU and UK regulatory body guidance. Does anyone want to talk about medical device classification with regards to AI?
I can respond to that. So I'm in the National AI Commission for the MHRA. So it really depends on the grade of data transformation. So during some of the initial discussions, it's certainly at least Class 1. But if the more the information is transformed or suggestions come in, you may come to A and things like that. So for example, I mean, AVT is a supercharged dictation system. Okay, and so dictation is not a medical device currently, and has never been. And so dictation sits outside. Many AI products at the moment are busy going through Class 1, which is self-certified. I think Class 2A will begin to play a role the more you introduce suggestions or summarizations or things like that, which requires a whole QMS process, a risk safety assessment, and things like that. So yes, in time, more and more will require it. In North America, the regulation is different. They've taken a more light touch approach, and so we will have to see how this evolves. But in the UK, certainly it's going to head towards Class 1 and Class 2A.
Brilliant. Thanks a lot for that, Prof. Okay, I think that's going to wrap it up for today. So that concludes the AVT Beyond pilot webinar series. Big thank you to all of the speakers who came, attended, and were able to share their insights and learnings to our audience across the NHS. And thank you to all of our attendees for taking time out to join us and to participate in these discussions. If you do have any more questions or you'd like any further information, please contact us at info@33n.co.uk. And thank you very much.